This is Mitchel Zoler from Global Medical News Network. I'm at the annual Congress of the European Society of Cardiology in Barcelona. I'm speaking to Professor Gilles Montalescot, who's a professor of cardiology at the Hôpital Pitié-Salpêtière in Paris. And he is presenting at this meeting a report from the GRACE Registry of Patients with Acute Coronary Syndrome, data collected from about 250 hospitals worldwide that looked at the outcome of about 1,800 patients who had unprotected left main coronary disease and had unstable acute coronary syndrome, including patients with shock and resuscitated cardiac arrest, and looking at the outcome of these very sick patients who got treated with various means of revascularization or no revascularization. So Dr. Montalescot, could you tell us briefly what you found from this analysis?
Yes, what we found from this large database is that clearly unprotected left main coronary disease in patients presenting with an acute coronary syndrome is not a frequent situation, but it's not also a rare situation. It occurs in 4 to 5% of patients. And it's a situation where we have no randomized study, no recommendation for the decisions that we have to take in terms of treatment and management. What we have seen is that whatever we do, we are dealing with very sick patients, high mortality rates, 7.7% of deaths during the hospital phase, 14% at 6 months. The death rate is 34% in patients presenting in shock. So really a difficult cohort of patients to treat and no guidelines.
Yes.
What we have seen is that along the past 8 years, we have seen more and more PCIs done to these patients. In year 2000, CABG was by far the predominant mode of revascularization. And since 2005, PCI has become the most common strategy of revascularization of these patients with unprotected left main and an acute coronary syndrome. And the sickest patients go really to PCIs, the patients with ongoing ST elevation MI, the shock patients, the patients with a cardiac arrest, while the patients that go to the OR for CABG surgery have a lower risk and are scheduled in general a few days later when they have been stabilized. And it's a different type of populations, and I think it's good news for us. We see that we have really now two strong options to treat the patients, PCI and CABG, while 8 years ago it was mostly CABG, and the interventional cardiologists were very reluctant to treat these patients into cath.
Yes. So these data really confirm that PCI is a viable option for these patients.
Yes, it makes sense also to use PCI in these very unstable patients, sometimes on mechanical ventilation, with shock, with ongoing STEMI. You wouldn't like to get a general anesthesia and an open chest in these patients in emergency. Now that we know how to deal technically with unprotected left main disease, we apply these techniques to the most acute patients, and the data are good. There is an improvement in survival at 6 months with both types of revascularization, PCI and CABG.
Yes, and finally you made the point that the registry data are probably the best that are going to exist for some guidance in this situation, that in terms of randomized trials that probably will never happen.
The best data, because the only data, there is no randomized study, and there will not be any randomized study in this situation because it's too difficult to do.
This is Mitchel Zoler from Global Medical News Network.